This visualization illustrates the concept of neurobiological dysregulation. Rather than a synchronized flow, these electrical impulses fire erratically, signaling a significant breakdown in the brain's internal rhythm. ADHD is a rigid neurodevelopmental disorder. It exists entirely outside the realm of behavioral choice, parenting quality, or personality traits like laziness. It emerges from a multifactorial origin. Strong genetic components are passed down through families, and these are often compounded by perinatal environmental factors, such as premature birth or low birth weight. These behaviors originate in the brain's executive functioning networks. Specifically, the neurotransmitter systems relying on dopamine and noradrenaline are dysregulated, failing to bridge the synaptic gaps and transmit signals. This chemical failure forms the core pathology of the disorder. This creates a unique clinical tension. The surface symptoms of this biological failure, forgetting keys, feeling restless, acting without thinking, are behaviors that every individual occasionally experiences. Effective diagnosis requires proving that these common behaviors stem from a pervasive clinical pathology. A clinician must find evidence that the symptoms are both chronic and severe enough to significantly impair the patient's daily life. To achieve a rigorous diagnosis, clinicians map these raw behavioral symptoms through the strict criteria of the DSM-5 diagnostic framework. Only then can they deploy an evidence-based, multimodal management strategy. The clinical evaluation begins with 3 raw inputs of symptomatic behavior: inattention, hyperactivity, and impulsivity. Inattention is the fundamental inability to sustain mental effort. A patient exhibiting this trait makes frequent careless mistakes, leaves tasks incomplete, and suffers from chronic disorganization in their daily routines. Hyperactivity manifests as excessive, inappropriate motor activity. These patients struggle to sit quietly and are often described by family members as being constantly on the go. Impulsivity is the act of taking action without cognitive delay. This looks like interrupting conversations, struggling to wait for a turn, or making immediate decisions without weighing the long-term consequences. These 3 domains overlap to create the DSM-5 clinical presentations. Highlighting the inattention circle reveals the predominantly inattentive presentation. Shifting to the others reveals the predominantly hyperactive/impulsive presentation. When all 3 intersect, it indicates the combined presentation, featuring all symptoms in significant numbers. Identifying the specific clinical presentation is only the first step. The surface presentation of these behaviors changes drastically across different ages and demographics. A persistent professional misconception dictates that ADHD is primarily a disorder affecting hyperactive young boys. In reality, female presentations often skew heavily toward the inattentive domain, lacking the disruptive physical hyperactivity that typically draws attention in a classroom setting. Symptoms like chronic daydreaming, forgetfulness, and severe disorganization in girls are frequently mislabeled. They are often diagnosed as having a quiet personality, leading to severe underdiagnosis in female populations. The diagnostic picture shifts again when assessing adults. The underlying neurobiology remains the same, but the outward expression evolves alongside age and responsibility. This comparative matrix illustrates the shift. Childhood hyperactivity, running and climbing, internalizes into adult inner restlessness. Adding inattention shows a shift from lost school supplies to adult executive dysfunction and poor time management. Silently, impulsivity evolves from interrupting teachers to reckless adult decision-making and risk-taking. Because these symptoms readily camouflage themselves within adult responsibilities and female presentations, clinicians rely on strict temporal and spatial filters to verify the pathology. The DSM-5 acts as a strict diagnostic sieve. The age filter requires symptoms present before age 12. The duration filter demands 6 uninterrupted months of symptoms. The threshold filter requires 6 symptoms for children, or 5 for adults. The spatial filter ensures symptoms manifest in multiple settings. If a child exhibits severe concentration problems exclusively at school, but functions perfectly at home, the clinician must reevaluate for environmental or learning issues rather than an immediate ADHD diagnosis. Surviving this diagnostic sieve proves the persistence and pervasiveness of the disorder, yet the clinician must eliminate one final layer of noise before confirming the diagnosis. Meeting the numerical thresholds of the DSM-5 is not enough. The clinician must systematically rule out mimicking conditions that cause identical functional impairments. Key differential diagnoses must be eliminated. Severe anxiety, major depression, bipolar disorder, sleep disorders, and specific learning disabilities can mimic ADHD. Furthermore, ADHD is rarely an isolated condition. It frequently travels alongside other neurodevelopmental and psychiatric conditions, complicating the clinical picture. Clinicians must simultaneously evaluate for common comorbidities, specifically oppositional defiant disorder, conduct disorder, and autism spectrum disorder. This requires objective data gathering from multiple sources. Clinicians utilize standardized tools like the Vanderbilt or Connors rating scales, collecting separate, scored assessments from parents and teachers to support the clinical history. Once the differential noise is cleared and the comorbidities are mapped, the ADHD diagnosis is confirmed. This immediately triggers the deployment of a comprehensive management strategy. Efficacious clinical management of ADHD cannot rely on a single vector or monotherapy. The approach must be multimodal. Clinicians rely on a 4-quadrant treatment matrix. Highlighting the first quadrant reveals psychoeducation, removing the stigma of behavioral blame. The second quadrant addresses behavioral and educational interventions, enforcing structured routines. The third quadrant, psychotherapy, offers specific utility for adults. Cognitive behavioral therapy targets the accumulated emotional fallout. It helps patients build vital coping skills to combat chronic procrastination and establish functional time management. These behavioral frameworks restructure the patient's external environment, but to correct the underlying neurochemistry, pharmacological intervention is frequently required. The fourth quadrant is pharmacological intervention. This chart shows 2 primary pathways. The stimulant pathway, utilizing medications like methylphenidate, improves attention and reduces impulsivity. The non-stimulant pathway, including atomic setting and clonidine, is strategically deployed based on comorbidities or side effect profiles. Because these medications alter brain chemistry, any ADHD pharmacotherapy requires mandatory, continuous clinical monitoring. Physicians systematically track precise physical metrics. They monitor appetite and sleep disruption, check blood pressure and pulse, and maintain crucial pediatric growth tracking. Long-term clinical tracking dismantles the myth that ADHD always resolves after childhood. For many individuals, these symptoms persist well into adolescence and adulthood. When clinicians combine a rigorous DSM-5 diagnostic evaluation with a sustained multimodal treatment matrix, they directly mitigate lifelong impairment. By addressing both the environment and the neurobiology, they restore the patient's functional capacity and drastically improve their overall quality of life.